Me too.
But so that's why it's important, right? So if you are in hepatorenal failure, that's why you'll see such a significant, one of the reasons you'll see such a significant drop in blood pressure is because it requires both systems.
Well, yeah, that's one piece, and then with hepatic failure, if you have something like cirrhosis or what do I want to say, like a viral issue, so you have like hepatitis, you have constant damage, which means you have constant inflammatory mediators being released. And this is why people who are usually in liver failure of some sort, to what degree, it's usually like more of the end stage, but people who have worsening hepatic injury and failure, they constantly will release some mediation, which then causes vasodilatation. So these guys will be, if they're not sick, they're walking around at Walmart with blood pressures in the 80s and 90s, and that's why sometimes when we have a patient like that, if you're talking about just kind of purely the hepatic failure, then it's sometimes like no matter how many pressors you run, you don't get like the best result. You know what I mean? Like you can't really drive up their blood pressure that much. And it's not necessarily like the usual pH issue, although that could be coupled with it if you have somebody who is super septic, really, really acidotic. Usually we consider that like below like 0.25, or sorry, 7.25.
Okay.
But yeah, so then you have this constant inflammatory mediation just pouring out around the clock, and these people, like I said, so why it's not super I want to say like how it doesn't impact them that much is because just this process is something that doesn't happen overnight, right? It's not acute, it's something that's more chronic, so therefore their body's adapted to it. So like with your kidneys, they're based on perfusion on a flow state, kind of like how your brain works, right? And so
Right.
when you're constantly having more vasodilatation systemically, that it will actually create vasoconstriction to allow for better flow in.
Okay.
So they've adapted to this low perfusion state to keep perfusion. So these guys will make, urine and stuff like that, but they're, like I said, walking around with these blood pressures in the 80s, maybe MAPS in the 50s, and they're still buying groceries. Then they come to your unit because they're super sick, and so now you have like a septic shock coupled with already hepatic injury, failure, whatever, and then they have more and more hypotension, and then they have this constant still inflammatory state. And so, you might have acidosis and you might have that. And so to have your pressors work effectively, it might take a lot of blood pressure medicine. And then if you have hepatorenal failure, it's like kind of a death sentence in a way. I mean, I think it's statistically, if you're healthy otherwise, which I don't know how people usually are, but I think it's like an 80%. I think I remember someone saying it was like 80% mortality.
Oh wow.
And then, but I don't know the statistics specifically, but I feel like I remember that number in my head
Yeah, that sounds great.
is like, it it's not looking good. And then you have other
People
problems.
seem fine too.
What's
And then
that?
I feel like those people seem fine. I
Yeah.
remember the first person I had, like as a new nurse, they're basically the doctor's telling me the patient was going to die in a couple of days. And I'm like, what? Like how? And literally 2.5 days later, he was dead. And he was like up, walking, talking, fine. And then he just like yellow, yellow, yellow. And then each system went down. I
Yeah.
was like, oh, God.
Yeah.
He was, it baffled my mind.
Yeah, it's pretty. I think the last Q&A I did, we were talking about CVVH, and there's a patient specifically, I want to say, in hepatorenal failure that we were kind of like talking about because most of the people on my Q&A worked in three, and this is where that guy was, and I had three upstairs, not the real three downstairs, but ended up just like you said, getting more and more yellow and just trying to scrub his blood clean, and I think they
Yeah.
did their best, but I think he just over time, it was like an
Yeah.
uphill battle. Hi.
Great. But Hi.
Welcome to my humble home. So,
This is fun.
yeah.
We should do it more often.
Sorry,
Wow.
Mark. I'm disconnecting this one because it is
I was freaking zoomed right
the
in.
battery's gone. Sorry.
Oh, you're fine. I do this once a month for anybody who wants to come, and I don't know all the answers. I do my best to answer what I can, and I think a lot of the newer people to the ICU
We're only using two.
appreciate this.
I appreciate it right there. Exactly the conversation I wanted to have.
Well, I appreciate you.
On red. Can I use this?
Yeah, of course.
Can we talk about a pet peeve of mine?
You can just be mindful. This is recorded.
Well,
But you can tell me any of your pet peeves.
The pick team's always texting me and calling, and they don't come down. They get on my nerves.
The pick team, you said?
Pick team.
I thought you were being diplomatic. Yep, no comment.
Is that going to be attached like so and so said? Da-da-da-da-da.
Yeah. So there's a little bit of frustration.
Yeah.
Cheers.
But he's awake, huh?
Cheers.
Chairs. Chairs and tables.
What else you got, Mark?
So this Q&A that I do is not a class. Like, it's not a specific class about anything. It's an open forum. So if you've ever seen some of the other ones that I've done, it's basically I log on, everybody who wants to come logs on, and people can come for all 4 hours. They can come and go, whatever. And it's just whatever people feel like talking about,
Yeah.
I don't come with an agenda. My agenda is sit here, sip coffee, and have people have an environment where it's comfortable, slow paced. There's not bells, whistles, family, patients. There's not a lot of distractions. It's just, I always tell people, have your coffee, get in your pajamas, and show me your animals, and that's it, So,
I wish my kittens were here.
Yeah, we're wearing pajamas. We've got coffee.
But
The only animal's Mel.
yeah, the wild animals let out of the cage.
Yeah, we do have bells and whistles here though, so we're going to be distracted. I apologize.
no,
I have
it's-
some questions. I just can't think of any of them right now because I didn't know that we were going to do this.
How would you suspect? So we've got a patient next door. This gentleman has an
Epidural abscess?
spinal,
I had him yesterday.
an abscess from C1 to his sacrum.
They think it came from his big toe.
Yeah, he has an
Yeah.
abscess on his big toe, and they believe that.
Yeah.
he has an abscess on his big toe. Is that what you said?
Yeah,
Yeah.
he has he's like a wicked diabetic and doesn't take good care of himself. And his big left big toe was like kind of not necrotic, but you can tell it's been like through pressure ulcer after pressure ulcer after pressure ulcer.
Okay.
And then he has like positive like MSSA bacteremia, like not an IV drug user, but he has this disgusting like pus-filled epidural space from C1 to his sacrum. And they went
So
in
his whole spine.
entire spine. His entire spine.
So can he move any of his
Yep,
appendages?
he has a spine neuro exam. Yep.
Okay. He
Say,
can breathe. Is he intubated? I'm assuming.
No, he's in the IMC side. I had him yesterday. I
Oh.
mean, his neuro exam was like totally benign. I
Okay.
mean, that's why, like, they took him to the office before, and they said they put a friggin' feeding tube up his back in his spine and like irrigated pus out.
Oh my
That's what
God.
Jesse, the NP, said.
A feeding tube?
I don't know what he truly meant
Like
by
a
that.
Levine tube? I wonder if it's one of those old-fashioned, really thin Levine tubes.
Probably.
Yeah. And they said they just irrigated it and flushed out like pus after piles of pus.
So interesting. Now I'm not sure. Do you have a question? Because I'm just imagining something like you have CSF in there. So are you sucking out all the CSF at the same time? Are you trading? Like, what are you doing? Is his brain okay? Does he have a really whopping headache? Is his brain like sagging on the base of his skull?
He was,
be a little somnolent, or
I mean, no, he like was alert oriented. I mean, he was an odd guy. He was like intermittently confused, but I mean, he got like Vanco, he got Zosyn, he got Ceftriaxone, and he got Cefepime, and now he's on Oxacillin. And they're just like, well, let's hope the antibiotics work. That's it. I'm like, so is he going to go back to the OR? Like, aren't you worried about like the C1? Like, drain that one at least.
Yeah.
They're like, no, unless his neuro exam changes. I'm like, well, he'll be dead.
Yeah, I mean,
probably.
so he doesn't have anything. He has no issues with his bone structure. It's just that he has this infection inside.
And it's literally everywhere. Like, they did an L1 through L5, like Lammy, like, gross.
For
I don't know. They did that as well.
does he have osteo of some sort?
I don't know. They don't know. They did an MRI. I feel like he has another like septic joint. I think his shoulder, but like they can't get it MRI because he's in so much pain. So you have to like move it out, and he like literally can't even lift it.
Yeah, no question. Sorry, I just thought it was an interesting conversation.
No, that's fine. Like I said, this forum is for whatever. It doesn't always have to be a question. I just was wondering if you're trying to ask me something, but more of it is that is interesting. Just the fact that
At that point, is it just antibiotics that you just hope takes care of whatever it is?
yeah. I mean, from what I know, yeah. And then I would think that if there was consideration for osteo and the vertebrae looked terrible, then when you said Lammy, I'm thinking, was there something so infected that it just makes more sense to take that out?
But it didn't really like. I mean, I can try.
I mean, when you think of like osteo, we treat it right, but like sometimes it comes to the point where it's so bad you have to amputate.
What's
Like if
that?
it was your leg. So that's why I think like if the infection was so bad and there was these specific areas of his spine that were so so involved that one, it could be actually affecting his neuro exam, and two, the likelihood of treating it was and recovering from it might be not great. So therefore, maybe that was the push to take out something.
Yeah, it's not clear from the note.
It doesn't say anything.
Yeah,
It just says
say-
L2 through L5 Lammies
Yeah. Did you hear that? L2 through L5 Lammy.
and drainage of epidural
And,
abscess.
yeah, and drainage. No debridement or...
That's all the neurosurgeon
Yeah.
says.
Hmm.
And ortho consulted.
Yeah, I mean, at this point, fingers crossed, just antibiotic therapy will get in there and do its job. And if it's you said MSSA? So
Yeah.
you probably have now you said oxacillin, so you have that like 24-hour oxacillin
Well, he's
infusion.
getting the 4 unless they changed it.
It's what?
It's every 4 hours.
Oh, not the continued infusion.
But why the difference?
Well, okay, so this is one thing, and I can't remember how this, like, what the translation is. I could Google it, but so, like, back in the day, we used to have Zosyn tubed out to us, already pre-made in a syringe. You put it in a syringe pump and deliver it. And then I think that as time has gone on, as infectious disease doctors were looking at stuff, analyzing it, and researching it, there's this thing called MIC, and so, which I can't remember, like, what that stands for. You just have to, could Google it. But what they're saying is that sometimes it's not just the drug being in your system, but how long it's delivered and at what sort of, think about like a level. So if you have like a flat plane as being 0 and you want to boost up that level of drug in their system, like Vanco is a stacking type drug because you need to excrete it, but this goes into your system, eventually gets metabolized and leaves. So the effectiveness of Zosyn isn't based on it's based on the dose, but it's more effective based on how long you infuse it for. So this is why we deliver it over 4 hours rather than just a whopping dose every 6 or 8 hours. So I have just come across my first patient, I think a week ago or 2 weeks ago, where they're doing oxacillin infusions around the clock rather than the Q4, which is what I'm used to. And I think it's based upon the same sort of understanding that maybe this is more effective based on not just having that dose in your system, but how long you're delivering it. So therefore, if you have a higher level of this drug in your system without a valley, you're probably going to be able to have more effectiveness on trying to treat that certain strain of bacteria, which in this case it was MSSA. And that's how I would understand it. This is my educational guess based on what I already know about Zosyn, and that I've seen this infusion. But this is one of those questions where, Chelsea or Katie or somebody, say, hey, is this why? Because I thought that recently when people were saying amoxicillin infusion, they were really talking about, oh God, I have to hang this every 4 hours, when in fact they were actually saying, I literally have a drip like TPN around the clock, 24 hours a day. And it was a very odd, I know the dose is standard, but it was like a 22.8 cc's or something weird infusion.
Yep.
941, right?
Okay, well, I had 30 or 27 maybe, or 29. There was another one in there a couple weeks ago for a young guy.
29 cc's, you mean?
No, sorry, in room number. Which one you had that in?
Oh,
do you remember?
I'd have.
Was he in one? Was he the guy that had the guillotine of his leg?
I don't think so. No, I was on the front side, not the island. I was on the front side.
Oh, okay.
Yeah.
I'm
Younger.
I'm just not. Oh, you know what? I think I know who it was. Remember, this is recorded, so I don't want to break any HIPAA rules. But I think if I were to remember, it was either 27 or 29, one of those two.
Yeah. Yeah, I had that same one then, I believe. And that was the same, similarly, that was my first interaction with that.
Yeah. So I think it's based on, hold on, MIC, I just can't remember what that actually stands for. Hold on.
MIC, medication, infusion.
Continuum.
Curriculum. Medically
induced coma.
Antibiotics.
Oh.
Minimum inhibitory concentration. There you go. It's the lowest concentration of an antibiotic that inhibits the growth of a given strain of bacteria. So, going back to the efficacy of Zosyn, it wasn't so much the dose within your system, it was how long you deliver it. So if you have that dose being pushed in for a long period of time, its effectiveness was much greater than just a dose in, metabolized out, dose in, metabolized out. Where Vanco is a stacking antibiotic, so you have it, but you have to excrete it. And if you don't, it's still there. And this is why people who go into renal failure, we have to be mindful of their function, and obviously there's that pharmacokinetic consult that automatically goes in when they order Vanco, and then the pharmacy will look at it, make recommendations. They'll look at wanting to do troughs every now and then, and just so this is what I would do with most of the people. I think you guys all understand this, but the group of people that would be on camera in front of me, I would say as a suggestion is when I look at my med list in the morning, who is that? I can't tell. Oh, is that Kissin?
No.
Rigatoni.
Oh, it's Tony. For a minute there, I thought it was Dave Kissin. Sorry.
Sorry.
Oh, no, you're fine. You're fine. But what I would say is that if you see Vanco on your med list, the first thing I think about is, do I have a trough? So I go right to my labs, look through, and see if there's a trough order.
I actually, now that you mentioned that, the MIC, I recall that because remember when we did that change for Zosyn?
Oh my God, it was forever ago.
Yeah, but I recall that. That's actually when as soon as you said that, I remember that back in the back of my mind, considering that. So do you remember, is it with that minimum inhibitory concentration, do we only dose that medication to achieve that minimum, or is it once it's a minimum, it's okay to be above that range and just dose it? Do you recall how that works?
So again, educational guess only here. I would say that I would say that based on certain medication, there's a toxic level, right? So as we know, nephrotoxic for Vanco being too high. So yeah, I think that there's probably a range that this is at least the minimum amount of effectiveness for this drug to even work. But then there's the opposite, which is true. You know, we're here in America, but not always is more better. So, you know, each category of drug has their own, you know, way of being metabolized. So you have the aminoglycosides, which most of them, I think, if not all of them, get stacked in your bloodstream. I know this only specifically to Vanco, but I'm not sure I've played with anything else before or in my past. I really don't know. And then, you know, let's take something like Cipro, which is a totally different type of antibiotic. You just give it, but it sticks around a lot longer, right? So its MIC is probably just based on that very general dose, but you know you can overdose. What to degree is that? I don't know. That would be something I'm assuming different for every single type of antibiotic, different categories, and your actual organ function, right? So, you know, some things are very much based on if you have a liver that functions or if you have kidneys that will, you know, actually excrete, filter, whatever. And so therefore I think that, yeah, there's got to be a top range too. But so these are the type of questions where if I'm not sure I can really answer that. So my job would be to then try to follow up on that and see if I can, you know, ask the right people, you know, phone my friends and try to get that information. Because questions like this, the forum, again, is for anybody to ask questions. I'll do my best to answer, but it teaches me because now I don't know the answer, so now I'll go find out the answer. So, you know, it benefits people here on the camera, on the side of my camera, but it also does benefit me. So I don't know exactly that answer, but my educated guess would be in my mind, there would definitely be a high end that you don't want to exceed either, because that could then be harmful in a different way. You know, maybe it's damaging to your kidneys, maybe your brain, maybe your whatever, you know.
Yeah, I'd be curious to know, just because like where we are, like you said, it's that rate for the 24 hours. You assume that they're assessing for that in the 24 hours, right? Because if you want to keep it within that range, you know, higher than the minimum, lower than the overdose range.
Yeah.
But if you're running 4 hours, that would be harder to achieve.
Yeah. I mean, and then, you know, I can't speak to all the drugs, but, you know, obviously we know some of them have levels that we can, you know, find out. Right, so Vanco obviously being one, but you know, do we have any consideration that cefepime, like at what dose is too much cefepime? Do we have a way to figure out how much cefepime is in your system? I don't know if that's a thing, but you know, it's obviously based on what they have for an infection, and then of course, you know, the dose, and then, you know, organ function. But if you were to double up on every cefepime, that's some way harmful to that patient, you know. In what way, I don't know. You know, maybe it hurts their liver, maybe it's cardiotoxic, you know, maybe it hurts your heart, I don't know. So, I mean, there's definitely a reason to have certain doses, right?
Right.
But each one I can't, you know, specifically speak to. So that's a great question where, one, I mean, I'll certainly ask when I see one of my fellow pharmacist friends, but that's also a great question if you're in rounds, just to ask, you know, hey, what would it be like if you overdosed, I guess, if you will, for lack of a better term, but on Cipro? I know one thing specifically to that drug is it lowers the seizure threshold, and I believe it does prolong your QT. So right there, having way too much of that particular drug in your system could lend to maybe torsades, maybe the patient who already has a seizure disorder can seize. Maybe you just push them way down, so now they're actively seizing. Maybe have a clinical or subclinical seizure. So right there, if you were to have a normal dose, we consider that. So then if you were to have too much of that in your system, do you quadruple those risks, you know, by doubling up on it or whatever?
Right. What's the mechanism on that seizure, lowering the threshold and then prolonging the QT?
Zero clue.
Yeah.
I don't know the pharmacokinetics of that at all. I just remember, oh, Gil Fraser, Michael. You know, I remember him talking about those things throughout the years. So sometimes, you know, it's not so much that the patient has an allergy to your particular medicine. It's just that they have such a bad seizure disorder already. Maybe we're already like literally like throwing them in a pen coma for the amount of seizures they're having, and they have X4A bacteria, and Cipro's great, and you're like, I want to use Cipro, and it's like, you can't because you're adding fuel to that fire. So what's the next best option? You know? Sometimes it's like, you don't want to use the dynamite, but maybe you're forced to use the dynamite because there's no other antibiotic that will work, and this is already the problem. So, yeah, Cipro might be kind of more pinpoint to that particular bacteria, but because of this issue already, I might have to go to Vanco, which is like, okay, that's the broad. We don't want to use that if we don't have to because we don't want to create superbugs, but maybe that's what we have to do for this patient because, you know. What's that?
But they would. Yeah, you would have had that. I mean, your sensitivities, right? You would have that. These are grooving.
Right. And that's why we have to pick and well, I say we, why they have to pick and choose properly what type of antibiotics, because it's not just focusing solely on like the bacteria, but then are we battling any other problems at the same time? So maybe this particular antibiotic might lend to other problems that we don't want to deal with. So the risk benefit there, maybe it's too much risk, let's go to the other antibiotic, but maybe the only next antibiotic that we have available that will treat that specific bacteria is something a bit more broad that we tend not to want to use unless we have to use it. That's why we know, like, we go big at first because we're just trying to make sure we cover anything, and then, okay, yeah, it's just E. coli. Okay, boom, we narrow it down to this one antibiotic. And then I know, you know, just a side note to that is sometimes we have to, and I say we, meaning pharmacists especially, we have to think about what we're treating and where it is, because sometimes having the same bacteria in a different location in our body, we have to consider how it penetrates that. And I don't know that mechanism, but I do understand, like, you know, if you were trying to get to your pancreas and there was an infection, certain antibiotics would be effective maybe to that strain of bacteria, but they don't get into that organ very well, where another one does. So yeah, maybe this would be effective as far as treating that strain, but this one is actually going to get where I need it to go. And so therefore it's kind of like upgrading your antibiotic. I have to do something a little bit broader, which I don't want to do, but I have to based on where this actual strain is located.
Right, and that, yeah, going back to that question or the comment about the epidural space there, interesting about that MSSA. And not a question. Sorry, there's a lot going on here, Mark.
No, take your time. I am here. I am just here. Don't worry about me. If you gotta go, go.
Anybody else joining you?
No, you guys are the only one. I'm here for 4 hours. So if you guys are here, otherwise if you guys camera out, then my day is done. So I'm happy to stay if you guys want to keep going.
We love you.
Marky Mark, when are we gonna go have some beverages?
I guess when COVID's over. No.
2025.
I'm having my beverage now.
Is he signed up?
Italian night.
Italian night?
Mark's gonna make gnocchi.
I make a gnocchi. I will give props to Graham, because when I had my first group of new grads over to my house, I made homemade gnocchi and sausages and stuff like that, and we were gonna call this, and this is his word, gnocchi knowledge. So.
That's a good one.
So today on Gnocchi Knowledge, we are talking about antibiotics.
Is everybody in your circle vaccinated or signed up?
For some have been vaccinated, some are had to wait. So my father was going to, but he just had back surgery, and he just actually left. So he's gonna have his 2 weeks out because they didn't want him having it before. So he's having his. I think my mom just had her second one today, and Charlie is. I'm not sure. Whenever, I'm not sure when he's signing up. I think is it this month or next month when you're in your 40s, or is it just open now? I forget.
16 and
Yeah, because Kim's brother just got his yesterday, and he's 40. So I think
It's open to everyone, Mark. Starting, I think it's either the 16th or the 20th.
This month or last month?
This month
Oh,
for
okay.
16th. Sir.
I wonder if he can sign up in a different county if he'd be more likely
You can
to.
get on a wait list at like a Walgreens or
Yeah.
something.
No, we can look. I in my mind I thought it was still like I think May was like 40 and above, and so I was thinking it wasn't until next month. But
Yeah, oh, they moved it up.
nice,
All right, we're gonna leave you, Mark.
no problem.
I appreciate the conversation.
Yeah, anytime.
Bye.
Have a good day, guys.
See ya, you too.
Bye.